Buddy, my name's Tom Chen, and I am a professor in neurosurgery at USC. And both Patrick and I have strong interest in spine oncology. And they asked me to talk to you today about innovations in spinal oncology. And next slide. I have no disclosures. Next slide. So I thought I'd start off with just showing you an MRI scan of a patient with metastatic spine cancer, and this is the sagittal view of his spine and spinal cord. And what you can see is basically that he has compression from a retropulsion, and that is indenting his spinal cord. And as a result, he has weakness and pain in his legs. And so you can see from this MRI scan that when we talk about spinal oncology and how to deal with it, we're basically talking about decompressing the area that's retropulsed. We're talking about reconstructing that area that we have been taking out the tumor and reconstructing it so that the patient does not have pain. And so just by way of background, I started off during residency, I wanted to do surgical neuro-oncology. And at that time, everybody was, a surgical neuro-oncologist was operating on brain cancer. And I thought that it would be really good if somebody interested in oncology would do some spine oncology, because at that time, most of the surgery was done by spine surgeons who weren't really interested in the oncology portion. And so that's how I got started with spine oncology. But you can see from this MRI scan that this is a very complicated problem. Many times the surgery is actually much more complicated than degenerative spine.
Your attention, please.
And so what I want to talk to you today is some of the advances that we have made in terms of treating this disease. Next slide.
Code stroke, Keck Hospital, 7th floor, 7 North, room 7223.
So when we talk about innovations, what I want to do is divide into two areas. First of all is what are some of the innovations in diagnosis? What are innovations in terms of surgical treatment? And what are innovations from the standpoint of adjunctive therapy? Next slide. So in terms of innovations in diagnosis, this is much more of a background now. I think that everybody now recognizes what the problem is. But to be honest with you, when I was doing my training as a resident in Norris Cancer Hospital, I oftentimes would go see a consult, and then we would have this patient with spine cancer, and the patient would just basically be lying in bed with all sorts of pain medications because that patient was in so much pain. And so recognizing the problem, recognizing the biomechanics of what's going on is something that we've made tremendous strides in, and something that I think is very important. And so we've done much better from the standpoint of recognizing biomechanics of spine metastasis, biomechanics of intradural masses. And I'm going to introduce you to some of these issues in this portion. Next slide. So in terms of recognition of the problem, I think everybody was always really hesitant about whether you should have do big surgeries on these poor patients with metastatic disease. And at that time, it was like, okay, should we just leave these patients alone, just give them radiation and not do anything else with it? And I think this study by Roy Patrol in 2005, published in Lancet and subsequently in Neurology, basically was a direct comparison looking at whether if you did direct decompressive surgical resection and compare that to patient and compare that with patients that were just treated with just radiation alone, who would do better? And then I think what Dr. Patchell showed was that, and they actually had to stop the trial early because the patients that had surgery did much better and actually had much better functional return. And so this was the first step to sort of recognize the fact that surgery and stabilization had a big role in terms of how these patients could do. Next slide. And so here's the problem in terms of understanding the biomechanics of spine metastases. And here, what you see here is basically a sort of like a progression of disease. You know, the bone basically is a big nidus for metastatic foci, just and so a metastatic focus of cancer cells goes to the vertebral body, and as the tumors grow, replaces by cancer cells, and then you get gradual collapse of the vertebral body. And then when you get gradual collapse of the vertebral body, it leads to retropulsion of some of the elements, and then compression of the spinal cord, leading to paresis or paralysis. Next slide. If you could go back again, Melody, sorry about that. And so what else I was going to say is that besides that, you can see how if the bone is destroyed, and then that can lead to a significant amount of pain because there's lack of stability at that particular region. Next slide. And here's another case. This is a patient with a intradural mass, a spinal meningioma. And you see how that nugget there of tumor is causing compression on the spinal cord. And so these patients with intradural masses, it's very interesting because they present with pain, but it's always not, it's more like a deep-seated type of pain. These patients will say that I go to bed and I have to wake up in the middle of the night, walk around because I have a lot of pain. And one of the reasons why that occurs is because when they lie down, there's more stretching of the dura. And when there's more stretching of the dura, that's how they feel like they have this deep-seated, knotted pain in their back. And that's what happens with intradural mass and stretching of the dura. Next slide. So what I'd like to talk to about you next, is some of the innovations that we've had in surgical treatment. And to me, from the spine oncology standpoint, there are three things that I sort of think of as being real innovations. And one is the O-arm. An O-arm is basically an intraoperative CT scan, and I'm going to show you some examples of that. Hemostasis, we have a lot better hemostatic agents. A lot of these spine cancers, they bleed a lot. And so to be able to achieve good hemostasis with hemostatic aid is very important. And then lastly, instrumentation, especially anterior instrumentation, that helps us with stabilization. And I'll show you some examples of that. Next slide. So here's an O-arm. An O-arm, it's called an O-arm. It looks like an O. It's an intraoperative CT scanner. And so that means that in the surgery, we can wheel the O-arm in, and then we can get a picture of how we're doing by just having the patient go through the O-arm and just get a CT scan. Next one. The beauty of the O-arm is that because it's intra-op, that means that we can use instrumentation and we can visualize what we're doing. And so what you see here is that with the navigational system, you see how the pink is the pedicle screw, and then what we can do is that we can look with the O-arm and use navigation, and then we can tell exactly where the pedicle is, and then we can tell exactly how we can direct the screw down the pedicle and make sure that everything's very accurate. I think this has been really a game changer, at least in my practice, in terms of making sure all the instrumentation is placed correctly and properly. Next slide. The next agent is the hemostatic agents. I use something called Surgiflow, and what these are basically collagen particles. And what we are able to do is that we're able to achieve much better hemostasis because we can just squirt the something like Surgiflow into that area and achieve hemostasis much easier. Next slide. And then the last thing I want to show you is some of the instrumentation. And I think the instrumentation that's helped me the most from the standpoint of spine oncology are these cages. You see, here's the person's neck, and that cage is basically expanding into an area where corpectomy has been done, and therefore it's providing good anterior support for that patient, and that allows the stabilization to occur easily. Next slide. And then here's a posterior instrumentation, and this is for the patient's neck from behind, and you can see how we can place screws, and then we can fixate that basically from occiput all the way down to the thoracic spine with this type of instrumentation. Next slide. And the last thing I want to talk to you about in terms of instrumentation is kyphoplasty. I think you've heard of kyphoplasty. It's basically where we inject cement into the bone. It's especially good for certain types of spine cancer where there's where the bone is in the way. And so one area that I use a lot is in multiple myeloma cases. In these cases, the bone is pretty much eaten away, and then I inject cement into that area, and then stabilize that bone. And then the patients with multiple myeloma usually respond very well to chemotherapy and radiation therapy. And so a small procedure like a kyphoplasty can stabilize that area and make that patient feel much better and with much less pain. Next one. And then the last thing I want to talk to you about is some innovations in adjunctive therapy, as particular radiation therapy that we use all the time, and sometimes in chemotherapy. Next one. So radiation therapy, I think that, one of the tools that we use a lot now is something called the CyberKnife. And CyberKnife is basically radial surgery, but it's radial surgery that's designed so that we can radiate different segments of bony structures and be very precise in terms of how that radiation is applied. The Norris Cancer Center has a CyberKnife that's used for spine cancer all the time. And I think it's a very big break in terms of from standard radiation to stereotactic radial surgery for spine cancer. Next one. And then the other thing I want to talk to you about in terms of adjunct therapy is something called separation surgery. This was sort of popularized in Memorial Sloan Kettering. But basically, the whole idea is that what we're doing, instead of trying to take out all the tumor, we take out the tumor that's affecting the spinal cord and essentially separate the tumor away from the cord, so that when the radiation oncologist gives the radiation, he has giving the radiation to the bone and the tumor and not to the spinal cord. And there's something called separation surgery. It's become very popular now, but the whole concept is to give radiation safely. Next one. And so in terms of wish list for future innovations from my end, I would like to see a fusion of operated area. I talked to you about new instrumentation, new screws, new cages, but the bottom line is that all our oncology patients are living longer. So when we place cages and screws, we don't really fuse that area because we don't use the patient's own bone and place it back because of the fact that they have cancer cells in there. And so we just usually use bone substitutes. which don't fuse as well. And so it's always been a dream of mine that we can eventually get a bone substitute that would cause a fusion as well as the native bone to help these patients, because now instead of living for a year, they could be living for a number of years, and we like to see that area fused if possible. And then my other wish list is to have better chemotherapy, especially for primary bone cancer such as chordomas and osteosarcomas. We currently do not have good chemotherapy for these types of cancers, and I hope that this will become something that we can develop in the future. Last slide. And so in conclusion, I want to say that, innovations in spinal oncology are expanding through recognition of what's available from an oncology standpoint, and also an understanding that spine surgery can help these patients, and understanding the biomechanics of what's happening. I talked to you about widespread surgical adoption via appreciation of biomechanics and new instrumentation and different approaches, and also in innovations from the standpoint of adjunctive therapy, including radiation therapy and chemotherapy. And so I hope today that I've given you a sort of broad introduction into some of the innovations that are coming, that are here in spinal oncology. And just know that, a patient with a metastatic spine cancer is not somebody that is doomed to suffer and become paralyzed as in the past. We can now do a significant amount of good for these patients and help them